Hi, I'm Dr. Christopher Gibbons. I'm a scientific advisor for C&D Life Sciences, and today we're going to talk about the evaluation of patients with autonomic failure. So the objectives in this case are to discuss diagnostic testing in patients who have autonomic failure and the role of phosphorylated alpha-synuclein to aid in the diagnosis of patients presenting with orthostatic hypotension and other clinical features suggestive of dysautonomia. So in this case, it's a 67-year-old woman with a 15-year history of hypertension and a 10-year history of type 2 diabetes that has been well controlled. Her hemoglobin A1C scores have been in the 6.1 to 7.3 range. She presents with a 1-year history of orthostatic intolerance and has 3 episodes of syncope in the last 6 months. She describes feeling dizzy and lightheaded when standing up quickly. The episodes of syncope have been witnessed, and they always occur while standing. She is described as sagging to the ground, but recovers within a very short period of time. Her cardiac evaluation, including echocardiogram, stress test, and loop monitor, have been unrevealing. She has been on both hydrochlorothiazide and lisinopril, but due to these orthostatic symptoms, these medications have been removed and no changes have been noticed. On review of systems, she has some urinary incontinence, but she's lost 10 pounds over the last 6 months, and she describes this as feeling full more easily after eating. She has not had any memory loss, no tremors, and no sleep changes. Her physical examination is unremarkable with the exception of her orthostatic vital signs. Supine, her blood pressure is 160/100 with a pulse of 65. While seated, her blood pressure is now 130/70 with a pulse of 68. While standing, after 3 minutes and feeling very lightheaded, her blood pressure is 90/55 with a pulse of 67. On neurologic examination, her cognition is normal with a MoCA of 29/30. Her cranial nerves are intact. There's no evidence of impaired smooth pursuit, nystagmus, or saccadic intrusions. Her motor exam is 5/5 with no rigidity or bradykinesia. Reflexes were 2s throughout, but they were absent at the ankles. Cerebellar testing is normal, and sensory exam reveals a mild link-dependent neuropathy to the level of the ankles. Her station and gait were normal. Now, there are a couple of questions here. Could her diabetes be causing this condition? Her hemoglobin A1C has always been within the recommended range, but if this is due to her diabetes, should we have a change in her target A1C? And then, are there other conditions that are being missed that need to be considered in the differential diagnosis? So this lists the most common differential in this particular case. And of course, diabetes, we know she has that, is at the top of the differential for causing autonomic dysfunction. However, we should also consider autoimmune and connective tissue diseases. We need to think about rare antibody-mediated disorders such as ganglionic acetylcholine receptor autoantibodies, which are sometimes linked to paraneoplastic syndromes, hepatitis C or HIV, amyloidosis, both inherited or acquired, and of course at this age, neurodegeneration has to be considered. Now, what might we do as a next step? Extensive laboratory testing could be considered for these rare diseases, and this of course would be quite a large array of tests and a gunshot approach to making the diagnosis. We could approach the watch and wait and see what happens over time to see if new symptoms develop and identify a more clearly diagnostic group of symptoms and signs. However, she's had 3 syncopal spells in the last 6 months, and this raises the question of whether a watch and wait approach would be appropriate. Finally, we could order the SYN1 test to evaluate for the presence of synucleinopathy. In this case, it might help support a diagnosis of pure autonomic failure. So in this case, we completed the SYN1 test, which were 3 small punch biopsies that were obtained in our office, and these were stained with antibodies to protein gene product 9.5, and these look at the pan-axonal marker and look at all nerve fibers in the skin. And they do reveal that there is a distal length-dependent neuropathy consistent with her diabetic neuropathy. However, there was also evidence of phosphorylated alpha-synuclein noted. And you can see this here. This is a blood vessel surrounded by PGP-positive nerve fibers, so these are vasomotor nerve fibers. Here in red is the phosphorylated alpha-synuclein, and this confirms a diagnosis of synucleinopathy. Down here in the third image, you can see the co-localized PGP 9.5 and phosphorylated alpha-synuclein. Now, given the clinical history, the absence of other signs of Parkinsonism, this confirms a diagnosis of pure autonomic failure. In this case, there were several items on the differential diagnosis, with diabetes and pure autonomic failure being the most likely. Now, diabetes can cause autonomic failure through both hyper and hypoglycemia, but by confirming the diagnosis of synucleinopathy, additional investigation into her diabetes control is no longer necessary. There is no need to test for additional paraneoplastic diseases, autoimmune disorders, infectious diseases, or other rare conditions. So this reduces the number of tests that we need to arrange for at this point. Now, the abnormal SYN1 test provides clear evidence of a synucleinopathy, and in this clinical setting would help confirm the diagnosis of pure autonomic failure, which allows us to move on to treatment of her orthostatic hypotension through a combination of non-pharmacologic treatments, such as lifestyle modifications by increasing fluid salt, adding physical countermaneuvers. We could add pharmacologic treatments such as fludrocortisone, midodrine, droxidopa, or pyridostigmine as needed. We also might want to modify her diet and consider prokinetic agents because of her symptoms of gastroparesis. And now, primarily, this also avoids unnecessary treatments for her diabetes. If we had erroneously presumed the autonomic failure was due to her diabetes, this might lead to further complications. Now, it's important to note that the SYN1 test provides an objective pathologic evidence of synucleinopathy, but it does not differentiate between the types of synucleinopathies, which include, of course, Parkinson's disease, dementia with Lewy bodies, multiple system atrophy, and pure autonomic failure. But in this case, the clinical history combined with the pathology support the diagnosis of pure autonomic failure. So we're happy to answer any questions about this and hope that this case was educational. Thank you very much.